Tools of the Trade, Hidden Populations, Including Adolescents in Your Research. A presentation of the Ohio State University Center for Clinical and Translational Science. The objective of this program is to help researchers become comfortable reaching out to adolescents for research that would benefit from including participants between the ages of 10 and 18, as well as adults and children. Here's the agenda for today's program.
Well, good morning to everyone. For those who are not familiar with me, I'm Andrea Bonney, the Chief of the Division of Adolescent Medicine at Nationwide Children's Hospital. And this morning I'm going to be speaking on the topic of ethical challenges and special regulatory requirements of including adolescents in research. I would like to acknowledge Brittany Manos, who's the research coordinator in my division, who actually helped me compile the information that I will be presenting today. So the objectives for this presentation, one is I'd like to review the ethical principles of research that really affect research with every participant, including minors. I'd like to consider ethical uncertainties around adolescents' ability to consent to research participation, and then understand the ethically appropriate situations where waiver of parental consent would be okay. So we're going to start with the case. We have a 17-year-old female, and we will call her Sarah. Sarah desires to enroll in a study evaluating weight gain and bone mineral density changes among adolescents who have selected to use the contraceptive implant. She has consented to the medical placement of the implant and desires now to participate in your study. However, the institutional IRB has required that for participation in the study that consent from one parent would need to be required, and neither Sarah's mother or father is willing to provide this informed consent. And so I'd like you to consider Sarah's situation as we go through our slides this morning. And we're going to get back to Sarah at the end and have a little discussion around the issues related to her. Okay, so to review the ethical principles of research, we have 4 ethical pillars. One is respect, which is the recognition of a person as an autonomous, unique, and free individual who has the right and the capacity to decide. Beneficence, which is really acting in a way to benefit others while promoting their welfare and safety. Non-maleficence, which is purposely not causing harm, excuse me, and justice, which is the fair selection of research participants. And these principles apply to all research, including research involving adolescents. When we think about adolescence, broadly, adolescence has been considered to extend from really the onset of puberty, which could be as early as 7 or 8 for some individuals, to relative independence from parental control, which some could argue is up to the ages of 25 or 26 years of age. But the term adolescence as used in this presentation is going to refer to individuals who are approximately from 9 to 10 years of age and up to but not including the age of 18, because by the age of 18, generally that is considered the age of majority, and individuals are allowed to provide consent for themselves for participation in research. So a little background, in 1998, the NIH called for increased representation of children and adolescents in research. And really, why did they do that? Well, prior to that, investigators and IRBs tended to interpret the 1947 Nuremberg Code, which had the requirement for informed consent, as implicitly excluding children. And really, this was on the basis of their limited intellectual and emotional capacity. So until the 1960s, IRBs really allowed clinical research with children only when that intervention offered a potential benefit over standard therapy, and that really tended to be in things such as cancer trials. More recently, in 2002, we had the Best Pharmaceuticals for Children Act passed, which really intended to promote research in children and adolescents. That act was reauthorized in 2007, and they gave it a little more teeth in the reauthorization. In the reauthorization, the FDA was allowed to issue specific requests for manufacturers for research in children and adolescents. And then this was followed by the Pediatric Research Equity Act, which actually mandated pediatric testing specifically of drugs that were likely to be used in the pediatric and adolescent population. So we have had movement forward, but despite this movement, adolescents continue to be underrepresented in research. And I think really the reasons behind this is there are several issues. One is researchers and IRBs alike struggle with interpreting federal regulations as they apply to this patient population. And so the federal regulations that we follow for clinical research, 45 CFR, 46, those same regulations apply to research with adolescents. Where the variation falls is in the interpretation, particularly regarding the following two issues, which is the capacity of an adolescent to provide informed consent and the protection of confidentiality for that adolescent, especially in sensitive or controversial issues such as sexuality or illicit drug use. If we look at adolescents and parents' views, we find that there's also little disagreement there. This study was published in 2003, and what they did is they actually put forth these research scenarios to parents and to adolescents to see whether they'd be willing to participate. Well, what they found was that there was agreement. 74% of the time, adolescents and their parents agreed on their willingness or unwillingness to participate. Where they disagreed, however, was that they both claimed that they should have ultimate responsibility for that participation decision. And so, hence, a little bit of discrepancy here with regards to adolescents and their parents' views. So we're going to first focus on informed consent. So in the research setting, consent is called informed consent. And the reason for that is that there are three essential elements. One is informed. It is the responsibility of us as researchers to fully inform potential participants of the description of the nature, the duration, the purpose of the research, its methods and means, and all reasonably expected inconveniences and hazards. The consent also needs to be voluntary, which that means there has to be no element of coercion in that decision. And the individual who's providing that consent has to have capacity, which is the ability to really appreciate the risks and benefits. And it is around these two last issues of voluntary nature of the decision and capacity where an adolescent's ability to consent can and has been questioned. So traditionally, for participation in research, Ohio law and federal law requires that we obtain parental consent for anyone under the age of 18. And it's generally accepted that for younger children, that they really do not have that decision-making capacity and that parental consent is and should be required. But the picture becomes less clear when we look at adolescents. As I mentioned, voluntariness implies that an individual understands that to which they are consenting and that they do not feel vulnerable. And in the absence of voluntarism, one wonders whether an adolescent can provide true informed consent. So some questions to consider. Is it possible for voluntary consent to be obtained even in the absence of full understanding? Is an adolescent child particularly vulnerable to parental or other authority? And are there actually specific situations that exist where that would place an adolescent would make an adolescent particularly vulnerable, such as examples of when they're under like duress for mental or physical illness? So assent has been put forth as a solution to the to this adolescent sort of gray area. So assent recognizes that children and adolescents may have some limited capacity and decision-making abilities. And some have suggested that assent be the standard for anyone under the age of majority. Assent addresses this sort of middle ground. It is in between what we call autonomous full consent and no involvement in the consent process at all. However, it's important to point out that assent is the process of agreeing with someone, concurring with someone to agree to treatment or involvement in the research, but it does not entail a demonstration of understanding or of reasoning ability. At Nationwide Children's Hospital, the IRB actually requires assent from a minor participant starting at the ages of 9 and up to but not including the age of 18. And I think that's pretty standard. I think you'll find that it's usually around the age of 9 where minor assent is actually going to be required. Now, there are some scholars, though, who believe that assent is not sufficient. I'm going to quote Loudon. Loudon actually wrote that childhood belongs to children least of all, and its study remains largely a study of adults' attitudes to and practices concerning children. Even when the criterion of competency is met, a child's right to exercise control over his or her own destiny has been negated by the courts. And adult beliefs regarding children's rights influences children's opportunities for self-determination. And they go forth and asking the question, is it ethically correct for adolescents to be considered still the property of their parents? Others have pointed out that assent does not actually equal dissent. So if we allow adolescents to assent, but we do not also provide the ability to dissent, then we are effectively giving them no decision-making power at all. So dissent is defined as an objection to participation, and it could be argued that if assent is going to be honored, then we have an ethical duty also to honor dissent. And by the present standards for adolescents, really the right to consent appears not to be balanced by the right to withhold that consent. Because if you look at our language and our assent documents, they are really couched in the language of assent and rather than dissent. So with that, let's consider the capacity of an adolescent to provide informed consent. There's been a couple studies I'd like to review, and one study that examined the relationship of understanding of the research participation to anxiety control and stage of cognitive development among a cohort of children and adolescents who were in an inpatient setting. And what they found was that the knowledge of research participation was actually related more to the emotional aspects of control and anxiety than to the age or the cognitive development of that child. What that meant was that in situations where children and adolescents were less anxious and they felt more sense of control, their knowledge of research participation was higher, and that we really should work to creating situations that are less stressful and have an element of control in order to help adolescents provide informed consent. In another study done by Laura Dorn and her colleagues, they actually used the test of understanding, which is more consistent with the law of informed consent. And this study included children as young as 9 years of age and up to 21 years of age. And what they found is that 14-year-old adolescents did not differ from young adults in their ability to understand the research. And so suggesting that adolescents as young as 14 might or probably have the capacity to provide informed consent. With regards to vulnerability, it is important to note that free consent may not actually be possible when others hold the balance of power. And vulnerability is defined as that sort of incapacity to protect your own interest, and that arises from being a junior or a subordinate member. So clearly that would pertain to minors and adolescents. And this position of dependence and vulnerability really could be experienced in any controlled setting, but it may actually be even worse in situations of crisis, which would further impede an adolescent's ability to consent. However, it's important to note that this belief that adolescents are highly vulnerable and easily influenced is not really supported empirically by evidence. And it should also be noted that when adults are hospitalized as inpatients, they're also considered to be dependent and hence vulnerable to a degree, but their right to provide consent is not invalidated unless there are other circumstances such as they're found to be incompetent. So some have put forth as the gold standard for consent for adolescents in research is what's called a relational narrative consent. And that states that the role that adolescents ought to have in research, consent, is in giving consent to the best of their ability. And that ability should be assessed by the researcher and the adolescent in partnership through what's called sort of a relational intersubjective process. And this could range anywhere from assent to consent. They propose this as a case-by-case assessment of capacity and vulnerability, and that even those who are not competent to consent for themselves, they are still owed the respect, justice, and inclusiveness to participate in the assent process. So theoretically, that really would be a gold standard, but I think in practice, that is really difficult to make a reality, and really difficult for, I think, IRBs to manage this as a gold standard. However, there are ethical situations where waiver of parental consent is allowed. So in 1997, the National Commission for Protection of Human Subjects actually recommended that individual IRBs be allowed to determine that parental permission be not required in certain research studies involving adolescents. There are really three areas where it's ethically appropriate to waive parental consent. And these are outlined below. So one, when requiring parental consent is not a reasonable requirement to protect the adolescent. Two, when the waiver would not adversely affect the right and welfare of the adolescent. The study poses no more than minimal risk, and the study could not be practically carried out without that waiver. And finally, in certain studies involving pregnancy, treatment of sexually transmitted infections, contraception and abortion services, an adolescent can provide consent and parental permission is not required. And on the next slide, we're going to speak a little bit more about those situations and why that's the case. But I would like to point out the reference on the bottom of this slide. This was the Committee on Adolescent Healthcare from the American College of Obstetrics and Gynecology. They published this committee opinion in June 2016, and it really provides a great rationale and justification for when waiver of parental consent can be justified and requested. And actually, Nationwide Children's IRB uses this document when they make decisions around waiver of parental consent. So it's a really good resource for researchers who are looking for some guidance. So with regards to those specific situations, if you read the federal regulations governing research, children are actually defined as persons who have not yet reached the legal age for consent to the treatment or the procedure involved in the research under the applicable law of the jurisdiction in which that research will be conducted. So it's really important for researchers to understand state laws around the age of majority, emancipation, and minor consent. And I would say generally, most states will give adolescents the consent, the ability to consent for medical care when it comes to contraceptive services and treatment of sexually transmitted infections. And so, according to federal regulations, in those settings, it may be justified and okay to allow the adolescent to provide informed consent to studies that pertain to those topics. Do want to mention, though, that for people who are going to conduct research in a school setting, at school settings, there are further regulations. There are federal education laws that govern research conducted in those school settings. And so researchers who are going to work in that area really need to understand those laws and abide by them as well. Okay, so let's go back to our case. So we had Sarah. So Sarah actually consented for the placement of the contraceptive implant. She wants to participate in an observational study. There's no intervention. They're going to monitor her weight and her bone mineral density. So there's some risk with the exposure maybe of a DEXA scan, but minimal risk. And but she would like to participate, and her parents are not willing to provide informed consent, which has been the requirement by her IRB. So if we look at our pillars, our ethical pillars of research, I could argue that in this case, we are, by requiring parental consent for this study, we are not respecting Sarah's ability to be an autonomous individual and make decisions for herself. We're certainly not being just. We're not allowing her just participation in research. And you could even argue that we may not have abided by non-maleficence because, for example, if her parents were not aware of her contraceptive decision, and the reason they became aware was because they were approached for her participation in a research study, we may have unintentionally caused some harm to Sarah. If we look back at that federal definition of children, so in the state of Ohio, Sarah has been granted the ability to consent for the medical procedure for the placement of the contraceptive implant. So in this situation, it would be reasonable to allow waiver of parental consent for her participation in this observational research study. Another document I'd like to make you all aware of is the Society for Adolescent Health and Medicine Consensus Guidelines for Adolescent Health Research. They were initially published in 1995, and then they were republished in 2003. And they really review consensus guidelines around adolescents' participation in research. In summary, they state that adolescents generally exhibit cognitive capacity to provide informed consent equal to that of young adults, that the content and wording of consent forms for adolescents should resemble that used for adults, and that assent absolutely needs to be sought out even when parental permission is obtained. And their last note is one last issue I'd like to mention, which is that researchers who are going to work with adolescents need to be prepared to offer assistance to their adolescent participants when health needs are identified in the course of the research. And that includes rapid referral for adolescents who exhibit an imminent risk of harm to themselves or others. So when we think about imminent risk, this is really identical to the clinical setting where we provide clinical care. In the case where an adolescent is deemed to be of acute risk to themselves, perhaps suicidality, or to others, homicidality, we in those situations have a duty to warn or to disclose to an appropriate authority or legal guardian. What I would say is that it is really the minority of research situations where this actually is applicable. And if you are going to be conducting a study where you think issues of suicidality, for example, may be disclosed, then it would be appropriate in your consent to mention to the adolescent that if in the situation where that is disclosed or uncovered, what your process is and to whom you will be reporting so that they are knowledgeable of that prior to choosing to participate in the study. And we do that in clinical care all the time. We explain to our patients when we have the duty to warn so that they are cognizant of that when they disclose information to us in the setting. And finally, if you have someone on your team who's comfortable with adolescent health care, they can really help you work through many of these issues. So in summary, adolescents are capable of greater involvement in the research consent process than is the norm. They should be treated with respect and dignity. Increasing their involvement in research has the potential to enhance their growing autonomy and capabilities. And I love this statement. This can be achieved in an environment in which protecting them from harm does not also mean preventing them from decision making. I think that's a fantastic statement, and I am not responsible for it. I found it. So our responsibilities are to protect our adolescents, to advocate to ensure that their voices are heard, to develop even more policies around adolescents' involvement as human research participants, and really to work to facilitate their meaningful involvement in our research endeavors. Thank you all very much.
So thank you very much. We're going to end this transition time. This is Pam Salisbury. We're just going to have a couple questions go up so that we have a sense of who is in the audience now that we're have the group together. And we would like to know the answer to 3 quick questions. Do you conduct research with adolescents currently? So it seems to be sort of stabilizing, maybe 50-50. The second question is, Is your interest in including adolescents coming from a pediatric research into including adolescents? And then the third question will be, are you an adult researcher trying to go down on the age range and include adolescents? So, Stuart, the second question. So I guess it's in one question. I didn't know how Stuart had put it together. Sorry, Stuart. And this will just help us. We also move into the panel, and maybe the panel members can also sort of help you, from the direction they've been working in. And so a little bit more from the adult down into the adolescent area. So this information should really work nicely for those of you interested in expanding your your research populations. So Stuart, back to you, and we can continue with the next speaker.
And we will bring on Catherine Vanetta and Jamie Jackson.
All right, well, thank you for your interest today in hearing us talk about measurement challenges when including adolescents in your research. I'm Kathy Vanetta, and we'll be trading off shortly with my co-presenter, Dr. Jamie Jackson. I wanted to start by reminding you about who we're here to discuss and why this period of life and research can be so challenging. When I ask my neighbors or extended family to define adolescence for me, they often focus on this being the group of kids that are teenage or high school students who experiment with limits, figure out who they are, or just become difficult to interact with. The Webster Dictionary provides a little bit more detail or a little bit different definition of this being the period of time following onset of puberty, during which a young person develops magically from a child into an adult. Scientists tend to get a little bit more specific or process-oriented and focus on the different domains of change: biological, psychological, social change, and you'll see some examples there on the screen. Just really marked areas of development that are all happening simultaneously during this transition period from childhood to adulthood. And you'll notice that in those definitions so far, none of them have really attached this to a concrete age range. And believe me, I searched for that because I think it's kind of convenient to have a specific age range of 12 to 18 or 10 to 25. Those were the kind of ranges that you can find if you look out there for a chronological age definition of adolescence. And partly that's because it's inconsistent in different uses of the concept, but also because this is a definition of adolescence that's kind of arbitrary and has evolved over time and changes between different contexts. But you will hear people differentiate adolescence into early or late adolescence with a fair amount of inconsistency. Health researchers often use biological markers as a way to subdivide the adolescent period based on onset or stage of puberty that research participants, for example, are in. And other kinds of research, education, or actually epidemiology, like with the CDC, often focus on different role transitions that have or haven't happened, like whether kids are in middle school or high school. And within Western cultures, there's been a general widening of the period of adolescence. And partly this is because of our progression toward earlier and earlier onset of puberty, but also because of delayed role transitions that come after formal education. And many of you will have heard of the period known as emerging adulthood, which rather than stating adolescence being such a broad age range, for example, 10 to 25, that emerging adulthood is a label applied to legal adults who aren't socially done with the kinds of role transitions and assumption of responsibility we think of as being hallmarks of finally accepting that adult role. And these different definitions and so forth, I don't mean to spend so much time on them, really are relevant to conducting research with adolescents and measure selection. So why would you be thinking about including adolescents in your research? Some people are interested in a specific stage of adolescence because that's actually part of their topic. Others focus on specific transitions or transition periods like AYAs. But often I think we run into measurement challenges because someone is planning a longitudinal study that covers very diverse periods of development, and how do you find assessments that can handle those transitions? And in healthcare settings, I think we're often trying to include adolescents in research because we're primarily interested in a rare condition that we want to study in childhood or in adulthood, and we want to maximize our sample size by pulling adolescents into that cohort. So some of the measurement challenges that we can face are that there is variability in what content is relevant to assess for adolescents that may not match up well with children or adults that are going to be included in the same study. And so the indicators of that construct or the constructs themselves may not be consistent. The format of assessments that are appropriate for adolescents may also differ from older or younger populations in terms of the language that is used or the mode of assessment that are preferable for adolescents, as well as what their concerns might be about privacy in the research setting. Then getting down to nuts and bolts, as with any kind of measure selection challenge, we want to make sure that we're selecting measures that have evidence of reliability and validity for each age group that we're studying. And again, when we're primarily trying to work up from a child-oriented protocol or down from an adult protocol, the measures we want to use may or may not have established psychometrics or norms within the adolescent population. So I'm going to try to use a selection of cognitive assessments as a good example of these challenges. And one reason this is challenging for adolescents, this area of assessment, is because adolescence is a time of marked cognitive change. And in particular, adolescents are developing a lot of executive functioning skills over the course of what we might consider an adolescent period. And so the tests that we select have to be age appropriate for them. And that's not just appropriate in terms of there being norms and evidence that the measures should be reliable and valid for them, but also that the tests or the tasks that we ask them to do are suitably challenging, that a wide variety of adolescents will have their skills adequately tested with that device. And so we don't want to have a ceiling effect where it's just too easy of a task for adolescents to complete. And as you'll see in the examples I want to provide, tests you're trying to use across a broad age range, or an area you want to assess across a broad age range, may require tests that have age-specific versions, or that you're selecting them based on the aims of your particular study. So I'm going to talk about two kinds of cognitive assessments we might want to select for a study. And one is just if you're assessing global cognitive abilities, which sounds like a pretty straightforward thing. Maybe you want to get an IQ estimate or get some broad assessments of cognitive domains. And as you can just see, I'm not going to go through these test by test, but that different test systems, some of which may sound familiar to you, vary in whether they are appropriate for a very broad age range or a very narrow age range. And some systems, like the Wechsler system, will have different versions of the task that are pretty compatible with each other in the scores that they generate, but it is a separate test that you would administer in different age ranges. And there's some overlap between those age ranges. I'll pause for just a moment and let you take a look at that. The second slide that I prepared on this focuses more on different measures you might use for more specific cognitive functions. And I mentioned that executive functioning skills are an area of growth for adolescents. So these different tests kind of focus on that, and also gives us an opportunity to show you might be thinking about whether you want to use an assessment tool that is has some technology assistance or is a digital format like the NIH Toolbox, whether they're more traditional clinical assessments, which also would give you a chance to generate norm-based scores and offer some clinical interpretation of the data that you're collecting. I didn't fit it onto the slide, but there are a lot of different, very specific research-based measures or measures developed by researchers to assess executive functionings that often lack norms altogether in terms of allowing you to make that kind of clinical interpretation, but might be very well suited to the specific aspect of executive functioning you want to measure. And then finally, that there are survey-based measures like the brief of more behavioral manifestation of cognitive deficits that then you run into challenges of what source of information or age group that you're trying to assess. All right, and by the way, I wanted to put a plug in here that these types of measure selection questions are something that the biobehavioral outcomes core that's supported by CCTS at Nationwide often is involved in helping researchers do both selecting measures and conducting assessments. So now I'm going to transition over to my colleague, Dr. Jackson, who's going to talk more about additional measurement challenges, particularly with older adolescents in health behavior research.
Okay, thank you, Dr. Vanatta. So when thinking about the older adolescent, particularly within the realm of health behaviors, there's a few things that I want to kind of bring up just for some context before we start talking about other types of assessments that we might be interested in if we're including an adolescent population in our research. So given that the older adolescent is going through a period of emerging autonomy, in the realm of health behaviors, this has several implications. So for example, and this is an area that is particularly relevant to my own research, older adolescents have less emphasis on physical education in school. And so as a result, they may actually have less structured physical activity built into their day. High school tends to emphasize more optional sports, the operative word there being optional. And so again, this is a consideration when thinking about health behaviors for older adolescents. Could physical activity and change in physical activity, for example, from childhood to adolescence, be of interest? Also, older adolescents are making more independent food choices now. particularly when it comes to school. They're purchasing their own lunches. Oftentimes they can even leave campus and purchase lunch outside of there, coming home, eating a snack before parents get home. So there is just a lot more independence with what their food selection is during this period of time. And lastly, there's a really strong influence of friends during this developmental period, which I also think plays an important role when we're thinking about assessments, particularly if we're wanting to include parent report as part of our assessment process. Are parents watching and observing different aspects of their adolescent's behavior as much as potentially friends might be, as an example? So let's talk a little bit more about some types of assessments for health behaviors that we might be interested in. So one of those would be the classic self-report measures that we often will use to gauge various types of behaviors, including health behaviors. So one important consideration when thinking about adolescence is the modality by which you'd be administering these self-report assessments. Now we thankfully have more technology at our fingertips, and we can collect data even more easily, I would argue, using an online platform such as REDCap, which might be familiar to those of you who are listening right now. I certainly use REDCap a lot in my own research, and it has a lot of benefits to it, including reducing just burden on research staff for having to enter data, just as one example. Now, when you're thinking about administering online surveys to adolescents, you should consider the context in which an adolescent is going to be completing this online measure. So even with like a REDCap survey, it's probably likely that a teen is going to be completing this on a cell phone, and potentially not in the most quiet, distraction-free zone. And so given that, you want to take into consideration how long the survey is, not only in its entirety, but also within each page of the survey before they have to click next to go on to the next page. How much scrolling on a small device like a phone do you want that teenager to have to do? And again, distraction being something that you'd want to keep in mind. Also, I had just alluded to this a few minutes ago about whether or not you want to include multiple sources when you're thinking about collecting data with older adolescents. Do you want parents to be involved, just as an example? And, you know, I think especially for children, obviously parents' report of children's engagement in health behavior is really critical. When you're talking about an older adolescent, there may be a lot of behaviors, as I had mentioned, that are less observed by parents. So what type of source would you want to include? And is it relevant to include parents? And if you want to include another source, multiple sources, parents or potentially peers, making decisions about how you're going to handle that statistically for your analyses is important to think about a priori. And one of the other considerations that I think is also important for us with this older adolescent group is the validation of the assessment tools that you're going to be using for your age range of interest. And Dr. Venata had already talked about that with some of the cognitive assessments, but I would like to revisit this for a moment in thinking about some self-report assessments. So let's take a specific example of the construct of health-related quality of life, which is popular when we're considering health behaviors. So similarly to what Dr. Venata had shown with kind of the lifespan listed below, let's visit just a few common assessment tools and how this kind of stacks up with where they fall on the lifespan. So let's start with a common tool, the Pediatric Quality of Life Survey, also known as the PEDS-QL, which is validated for the ages of 5 to 17. So with the PEDS-QL, I would consider one of the positives of this measure is that you also can get along with it a valid parent report if you're interested in multiple sources. And so particularly, again, with children, it's helpful to be able to have a measure parent report to accompany the self-report you may be receiving on the children. However, when it comes to older adolescents who are completing the PEDS QL, and again, we're talking about high school age, so 15 to 17, the questions that are asked are pretty much the same identical questions almost for younger children as what a teenager is going to be completing. And some of those questions just may not have as good a face validity for an older teen that's completing them, and they may think of them as less applicable to some of the elements of their life that they're encountering during that time frame. Now, on the flip side of that, let's think of another commonly used measure for health-related quality of life, which is the SF-36 or RAND-36. This is validated in adults 18 and older. The items that are on the SF-36, I think, are very relevant for even high schoolers. So again, I think the face validity works well with the SF-36. However, again, this is not an instrument that's designed to be used with an adolescent sample. You don't have the ability to get multiple reporters using the SF-36 like parent report. And if you use this within an older adolescent population and you attempt to publish it, as I have, you may get a little bit of pushback from reviewers because it hasn't been validated in that younger age group. I will say, in my own research, the internal validity of this measure holds up well in an adolescent sample, but once again, this is not the intended age range that it's supposed to be used with. Now, we also have access to a measure called PROMIS that came from the NIH toolbox. Now, the PROMIS has been validated for self-report in ages starting at 8 all the way up through adulthood. So a positive of the PROMIS is that, you know, not only does it have such a long applicability to a long lifespan, being from childhood all the way up through adulthood, you also have, for 17 and under, the ability to get parent report. Now, one of the possible downsides, and as you can see for face validity here, instead of a plus or a minus sign, I have a circle. And what I mean by that is the individual items on this measure for a high schooler are even more relevant than what I would consider the way the PEDS QL is worded. However, they still refer to teenagers as children in the measure. And so in my own research, I have had to replace that, or I felt the need to replace that with the word teen instead of using the word child. So there are, again, just considerations thinking about high schoolers, how some of these various measures will line up. So kind of coming back to this whole thought of an 18-year-old, as I had mentioned with the SF-36, you know, when we're thinking about 18-year-olds, and I know Dr. Venata had raised this question too, that these are technically legally adults. They can consent for themselves to participate in research. However, I think many of us would consider an 18-year-old has a ways to go as far as their developmental trajectory before we can consider them an independent functioning adult. That being said, you have to kind of make a determination in your own research for an 18-year-old. Is that person going to receive the same questions that you would give a 16 or a 17-year-old? Or are they going to get questions that, for example, you would give a 21 or 22-year-old? Now, in my own research, we have, instead of thinking about this in a more chronological sense, we've thought about it in more of a developmental sense. So if I have an 18-year-old who is still in high school and who's living at home, I would give that individual the same items or questionnaires that I would give to, for example, a 16 or 17-year-old. Now, if that 18-year-old has moved out of the home, is no longer in high school, is living independently, maybe even working, that 18-year-old seems to be serving or functioning essentially much closer to maybe a 21-year-old is. And so then I would give that individual what I would call the adult measures in my study. And, you know, I think in thinking about the measures I had just shown you, it's also important for us to consider whether or not there's the potential and possibility that you would be looking at longitudinal data collection and including those older adolescents in that longitudinal follow-up. And if that's the case, you're really going to want to think and pick and choose which of those measures is going to make the most sense to follow that sample over time. So given that we've got limited time today, I would love to talk a lot more about various objective measurements of health behaviors, which is something else that is often included in health behavior research. But today I'm going to focus in particular on physical activity, which is something that I use a lot in my own research. And one of the gold standards for measuring physical activity is the use of an accelerometer. And in my lab, we use the device called an actigraph. That accelerometer, which is pictured on the lower left-hand corner of the screen, is kind of what looks like a small red pedometer that is worn with an elastic band around the waist, and it sits on top of the hip, and the device itself has to be oriented in a particular direction. And we ask the participants wear this device for 12 hours a day for 7 days, which you can imagine is not that exciting to a teenager. But nonetheless, we have a lot of success using this, this objective measurement of physical activity, but I do think it would be helpful to bring up a couple of the challenges that we have encountered and are considerations for you as well if you were to include such a measure. So because parents are not as involved in the teens' day-to-day activities, including their not getting their teen dressed in the morning, teens are doing that themselves, remembering to actually put the device on, wear it, and return it to us can be a bit of a challenge. You know, of course, we do a lot of text reminders and things like that for our adolescents to try to help them remember. We also use a cloud-based platform that comes along, you can purchase along with the actigraph system that will, if a participant actually uploads their data using their phone, then we can actually tell whether or not the device is being worn. But once again, it requires that participant to remember to even upload it. So there are a lot of reminders that have to happen. There's also limitations as to what activities can be assessed with the accelerometer. They can't be worn in the swimming pool. If a participant is bicycling with the device, then it might not pick up on that activity very well, and they can't be really used very well in contact sports such as football. So once again, just thinking about why are you measuring physical activity and in what age group may determine whether or not this is the device for you or even the type of objective measurement that you would like to use. And then lastly, and we found this particularly challenging with this device, is processing the data once that data is collected in the device. So with the actigraph devices, you can use their software, Act-to-Life, in order to essentially pull that data and have it labeled as either sedentary, light, moderate, or vigorous levels of physical activity. And to do that, the software will ask you to select an algorithm which has been validated in either children or adults. There are no algorithms that are validated for older adolescents. And I can tell you that teens don't have the same physical activity patterns as children, and they don't have the same physical activity patterns as adults. And so, you know, happy to answer questions when we get to that, that part of the discussion about what my lab does. But needless to say, I think what's important for all of you to just kind of think about is making sure that you do kind of the legwork a priori to determine how you're going to tackle that specific type of issue with this objective measurement. So in conclusion, you know, there are multiple developmental and practical considerations when you're incorporating all of these types of assessments, be it cognitive, self-report, or objective assessments in your research. But don't let that deter you. This is a really important developmental age group to be researched, and you should be involved too. Think through the information that you want and can obtain from this particular sample. And I think if you really ask yourself why you want to include adolescents in your research, that will help you as a guide to selecting the measurements that are most appropriate for you. And just remember, reach out and get help. Team science helps everyone. It's important to have collaborators, and there's folks like Dr. Vanatta and myself that are here willing to help, and there's others out there as well. So once again, don't let that deter you. So thank you so much for your time. Here's Dr. Vanatta's and my email in case you ever want to reach out and ask us any questions, and appreciate your time and attention today. Thank you.
And our next speaker will be Dina Chisholm to talk about issues of health literacy and the transition to adult care and the implications for research.
Thank you. Sorry about that. I thought there was going to be a transition in between, so I wasn't totally ready to just hop right in there, but I am now there. So first of all, good morning, everyone. And I'm going to build upon a lot of what you heard from Dr. Bonney this morning and from Drs. Vanatta and Jackson. And I'm going to speak specifically about an area that I work in, which is health literacy, and really understanding how health literacy is something we need to be thinking about as we are doing this work. So let me see if I can make sure I've got my slideshow displaying correctly. Okay, are you guys seeing this slide screen or the note screen?
We're seeing both the slides and the notes, Dina.
Yeah. Okay, how's that?
No change.
No change.
There you go. There, it's come through.
Okay.
I think
So I do work in teens, particularly teens with special healthcare needs, and other medical and social complexity. So that could mean teens with chronic disease. It also means teens who have social factors that challenge their health and well-being, that being physical health or mental health or functional health. So that includes work with racial and ethnic minority groups, that includes work with sexual orientation and gender identity youth, as well as those with income issues and special healthcare needs. So most of my work is about teens. And so part of what I have to spend a lot of time thinking about is thinking about youth holistically, and thinking about how they have the skills and the capacities to participate in the research that I'm proposing. So Dr. Bonney spent a good bit of time this morning talking about the capacities to participate in consent and assent, to be an informed decision maker, to have the autonomy to make decisions about research participation. And Drs. Vanatta and Jackson spent time talking about the idea of measurement in those populations and what tools are validated for high levels of measurement and age-specific validation around tools. So what I think about is, for both of those things and for a bunch of other things, an underlying skill set that the youth needs is the ability to understand written and numerical information, because all of those things start with the ability to understand written and numerical information. And that's what we're talking about when we talk about the term health literacy. So sort of the standard definition for health literacy is the ability to find, understand, and apply health information in a way that allows informed decision-making. So that's what I'm going to be talking about more broadly. So like I said, I work mostly in a space called children with special healthcare needs, which includes about a quarter of the population. It is overweighted towards socioeconomically and disadvantaged families, and has children who are more likely to have unmet medical needs because they're more likely to have medical needs. And I work at the point of transition, which is sort of thinking about, for young people, how they are able to move from being under their parents' leadership and guidance into being in their own leadership and guidance. One of the terms that Dr. Jackson just used was the idea of, when do they become an independent functioning adult and how that determines our measurement models. The reality is that can determine our measurement models, but it doesn't always determine what we expect of young people in the real healthcare world. So depending on the stability of your household, depending on your parents' situations, depending on a lot of things, people are asked to take responsibility for their health long before any of us would call them independent functional adults. And they're responsible for making their own visits and responsible for filling their own prescriptions and responsible for managing their own diet long before we would say that they're, fully developed cognitively or emotionally. And so when we're functioning in a world of research about how kids keep themselves healthy, we have to function in the reality that they're going to be asked to do that in many cases long before we would be happy. And we have to think about how we develop the tools that allow them to do those things. This is just some data from the Ohio Medicaid Assessment study that was done several years ago, and it's been redone, and I need to update this slide. But what you can see is that as youth move from being under parental care to independence and young adulthood, we're seeing significant falling off of successful health management. And that's the space where we have a lot of opportunity for research. But doing that research, as I said before, requires that people understand what they're consenting to and understand the measures that we're using and understand the behaviors that we're going to be asking them to do. But when we look at data in adolescents and young adults with chronic illnesses, like I said, my population, we see that if you ask them about whether or not they're able to understand health information, fill out forms successfully, about 2/3 of them say, yeah, I can do that. When you assess it, and I'm going to talk about these assessments a little bit afterwards, but when you assess it measuring a tool that focuses on their reading or word recognition skills, so not asking them, but measuring them, about half of them have what we would call adequate health literacy. And when you assess them using a tool that actually makes them make decisions based on a combination of words and numbers, it falls down to 2 out of 5, about 40%. So there are meaningful and important limitations in health literacy in the populations that we are doing research with. And that differential actually matters, because when we look at data about differences in transition readiness based on health literacy, what we see is those with less than adequate health literacy, there is lower readiness for taking on disease management, health management behaviors. And this is using a tool called the Transition Readiness Assessment Questionnaire and using the REALM, which is one of those reading-based health literacy assessment tools. And what you see is that whether we're talking about their overall readiness, their ability to advocate for themselves, or their ability to manage their own health, health literacy matters. When you look at how they use healthcare utilization, you see that for well visits, it's about the same number of well visits in a 6-month period following an index visit where we assessed health literacy. But when you look at emergency department utilization, you see that the lower, less than adequate health literacy population is more likely to be in the ED, which may reflect a fact that they're less likely to have had the skill set to understand what they learned in the well visit or to apply what they learned in the well visit in a way that kept them out of the emergency department. And a paper that we have coming out soon in the Journal of Patient Education and Counseling, we also looked at sort of how young people are communicating with their providers. And this particularly matters if you're doing clinical-based research. And we assessed health literacy and asked about their perceptions of their communication and their time spent with their provider, and saw that that young people felt that the provider didn't listen to them as carefully, didn't provide them with specific information, didn't value their customs, didn't make them feel like a partner. Consistently when you talked about less than adequate health literacy population. So the ways that we're communicating with lower literacy populations are not meeting their needs in the same way that we're meeting the needs of children who have adequate health literacy. So all that is to say that health literacy matters, and that we need to be thinking about it in care and also in research, particularly when you're doing clinical research that links the spaces between research and clinical care. There's a lot of different ways that we measure health literacy. That includes, and I'm going to talk just about a couple of these, some that are more research focused, some that fit better in the clinical space. The test of functional health literacy in adults called the TOEFL, and there is also a short version of the TOEFL and a brief version, which is a little longer than the short version. And my team has done some research around validating it for adolescents. Is considered the research gold standard for health literacy assessment. It uses forms, so simple versions of forms. So one of them is an appointment reminder sheet. One of them is a diet reminder sheet before a procedure. And what it does is it takes that informational sheet we would give to any patient, drops out every 5th to 7th word, and places it with a blank, and gives you 4 choices of words that could fill in that blank. So what this does is test whether or not you understand words in context of the instructions that you're being given. It also has some options for testing numeracy that involve giving you prompts and having you make informational decisions based on the medication label or the appointment slip documentation. It is, a good measure of what it is we're trying to measure was, can people take in health information? It's a little time consuming and a little bulky in actually how you implement it. So it's not used in clinical care much, or even in a lot of research that doesn't have a ton of time, but it is sort of the gold standard. Beyond that, we use the rapid evaluation of adult literacy in medicine called the REALM. There's also a teen version, so the REALM Teen, and a team that I was on has also developed a REALM Teen short version. There's a REALM long version. And this is involves looking at words and being able to read them correctly. Whole list of health-related words, 66 of them, and you're scored based on how many you read correctly. It does not assess understanding, but it does assess reading ability and largely familiarity with words, because a lot of our reading of words comes down to our familiarity with them. The newest vital sign, which is a tool that I mentioned, is actually based on a ice cream label. So they get an ice cream label and they're asked to answer 6 questions that require you to interpret the information on the nutrition label. So it involves reading and numbers. There is a set of items called the CHEW items. They were developed by Lisa Chu in the VA. And there's a briefer version that is 1 item from that set. And these are really self-report items. So the first 3 are assessments where you're actually measuring things. The 2 items basically ask you, do you feel comfortable using forms? Do you ask somebody to help you with those forms? Do you feel like you're able to understand written information pertaining to your health? So that is important, and I'm going to tell you why the difference between self-assessed and scored measures in a second. There's also a number of disease-specific tools. And so there's a disease tool for diabetes and a tool for asthma, and a tool for a whole bunch of other conditions. There are population-specific tools. So there's a tool that's just for parents of young children. There's a tool that's just for Spanish speakers, which is a version of the realm that's been translated into a tool called the Salsa, which is kind of a cute name. So those exist. And then the other piece is sort of asking. But when you're thinking about how you do your research and you're thinking about the fact that you're going to have young people doing an assent or doing a consent if they're emancipated or if you've got a waiver, how are you deciding whether or not they have the literacy to be able to understand that form? How are you assessing that? Are you just saying, hey, the tool's written at a 6th grade level, so I assume they can understand it? Or are you doing some assessment of the youth? And if so, what sort of assessment are you doing? So I'm going to talk to 3 specific quick questions that I thought about when I was putting this together. One, what is the role of the parent when the adolescent is the participant? Dr. Bonney gave a great overview of the assent and consent model from a IRB, an ethical component. I want to think about it from a health literacy component. So some of the work that we've done has looked at health literacy in children and in their parents and looked at concordance. And we used a couple of different ways of measuring it. We used the realm, which was, as I said, the word recognition tool, but then their self-reported comfort with written material and their self-reported comfort with numerical material. And what we saw was that for self-reported, we had concordance between the child and the parent, which is either both high or both low, in about 55% of the respondents. What we saw was that only the parent was health literate in about 31%. So the child didn't have what we would call adequate health literacy. And depending on whether you looked at numerical or written, there were a lot of situations where only the child had adequate health literacy. The parent did not. So we're sort of relying on the parent to be the one who knows stuff, but that's not always going to be the case. And in a lot of situations, it will be the child who has better skills, the teen who has better skills for doing those things. And then 8% where neither of them had the skills to be able to do these things well. So as we're thinking about, well, we don't have to worry too much about understanding because the parents are there to support them, whether through the consent and assent process or through the study protocol. We need to start with the assumption that that's not always going to be the case. How do we think about literacy and diversity? Not surprisingly, we have racial and ethnic disparities in health literacy that align with the types of disparities that we see in health in general. And there's probably some correlation between those things. When we look at disparities in self-reported health literacy in teens, what we've seen is interesting because we've seen that when we look at those self-reported measures, so asking them how comfortable they are with using written information, with using medical forms, with whether or not they need help with reading things. None of these differences by African American versus non-Hispanic white are significant. Overall, African Americans appear to be slightly more likely to say they have skills, but these are not statistically significant differences. But when we actually use an assess tool like the realm, you see that there actually is a significant disparity between African Americans and non-Hispanic whites. So what this tells you is, yes, you can just ask, but just asking is not always going to be sufficient because people's perceptions don't always align with the assessed realities. And particularly in populations where people have been asked to step up and do these things themselves, maybe earlier than we would have liked, they may have developed the perception that they can do these things, but that may not be the truth. And so there is a risk that people have developed a unrealistic self-assessment of their health literacy. And we're seeing that in this data, particularly around teens. So it's not sufficient just to ask. There needs to be assessments as well. And we need to recognize that there may be subpopulations that need specific consideration around the literacy level of the tools that are used. Want to talk real quickly about technology as a front door to research engagement for teens. That seems to be everybody's favorite statement is, we can just use the internet to engage teens, because teens are, internet natives. Adolescents are internet native or technology natives, and so that's the preferred model. And, there is data that supports that, but I want to push back on it a little bit. Right now, we're in a world where we expect all of our patients, including our youngest patients, to interact with technology quickly and as their front door to healthcare, whether it's scheduling appointments or refilling prescriptions. As we've gone through this COVID life, the development of televisits, being able to get their results or send emails or communicate with the doctors through portals, messaging their doctors, all of those things are expecting a fair amount of e-health literacy, which, similar to health literacy, is being able to obtain and evaluate information from electronic sources. And we know that teens are living electronic lives. This is some data from 2018 from the Pew Research Center, which looks at youth and says, their tools that they use a lot are things like YouTube and Instagram and Snapchat. Interestingly, about half of them say they use Facebook, but a much lower percentage say they use it regularly. So we need to think about mapping our ideas of online platform use onto young people. They are using it, but it may not be in the ways that we think. And, we've gotten to the point where we believe that access to devices is ubiquitous, and data suggests that access to devices is largely ubiquitous. But I'm going to tell you that this slide, while true from a survey perspective, is an absolute untruth from a research implementation perspective. While people do have these computers or smartphones at these levels, the question is, do they have a data package? Do they have a data package at the end of the month, or have they used up all their minutes and all their data by the 18th? Do they have access to the phone, or has their parent taken it from them? Do they have access to the laptop, or is it one for a household of 7 people? And they say, yes, they have one, but the reality is they have no access to it. For us to assume that just because young people are digital natives and just because there's high penetration of these tools in households, that we can use those as a research tool for engaging young people, and they're going to have the access along with the literacy levels to do that, is unrealistic. And we've got to think about these things hard when we're doing our design. We've spent a little bit of time doing that in my research team. So we've been doing focus groups with adolescent girls to understand how they use the internet for health information. And we found that, there was a report that, they do use it all the time because it's quick and easy. We talked to their parents as well, who said they believe that it's quick and easy, but they're not sure that they're using it correctly or they trust the information. And suggested the idea of the value of sort of a crash course. And just a few quotes from the focus groups that we did. You can see young people talking about trying to use online information, but not understanding it or being overwhelmed by it. I love the third one that says, it's really good because you're looking up oh, why do I got a pimple on my neck? And then the first result is oh, you got lung cancer or something. It can be something that is completely off. So the idea that young people trying to use information may not be getting the right information, may not be evaluating it correctly, may be scaring themselves or making bad decisions. And quote from a mom saying, you know, I mean, it concerns me because it concerns us as adults, some of the stuff we find. I'm trying to imagine my 15 to 16-year-old looking at this stuff and knowing as much as I do and literally freaking out. So parents feeling like, even though they struggle with information, so they know their child must be. This is a shameless plug because I get to do a shameless plug when they make me talk. If you go to the Nationwide Children's Hospital website and enter eTeen Health, it'll take you to a series of pages that we developed as part of a project that was funded by the 31 Gives Foundation on how to use online health information. So it includes health literacy and e-health literacy appropriate tips for teens who are using information online. So there's videos and also cheat sheets for young people to use and for you to share with your patients or your research participants. So please do feel free to use that resource. So our take-home message is that we do need to include teens in research of the conditions and behaviors that affect them. They're the ones who are going to make the decision about taking their medicine every day. They're the ones who are going to make the decisions about exercising. They're the ones that are going to make the decisions about diet. And if we don't include them in the research, we're not going to get the results that we expect. For teens, for some teens, health literacy limitations are going to make that hard. Parents aren't always going to be the solution. And therefore, we have to think about health literacy as an important consideration, not just in the consent forms and writing them at a certain grade level, not just in the recruitment flyers and writing them at a specific reading level, but really the soup to nuts design of our research. Because teens aren't just big kids and they aren't just young adults. They are their own category of human with their own set of challenges, including health literacy that they have to address. So I just want to share the team that pulled together a lot of the data that is in here over the years and our funders and my email. Thank you for your time.
Thanks for that really wonderful group of talks. I appreciate everyone sharing your expertise in all of these areas, and hopefully that'll be helpful for folks thinking about including adolescents in their work. We're going to have a panel discussion. We're running a little behind on time. So I'd like to have our panelists just briefly introduce yourself and hopefully talk a little bit about some of your successes, challenges, failures, and trying to engage some of the special groups that you all work with. And maybe we can go in alphabetical order first with Jody and try and keep it about 5 or 6 minutes initially now, because we want to save some time for questions for all of you and also the larger group if possible.
Great. Thank you so much for having me today. I want to talk about one of the arms of my research focuses on understanding the effects of adversity on the health of youth experiencing homelessness, including the mediating effect of biological stress in this relationship. And all of my research in this area focuses on youth who are unaccompanied by an adult caregiver. So as you can imagine, there's quite a few challenges to conducting research with this vulnerable population of youth, including the regulatory issues that were discussed before in health literacy as well. But 2 key points that I wanted to touch on specifically in working with this population is first the need to recognize that the majority of these youth have a significant history of child abuse and neglect that they experienced in their home setting prior to becoming homeless, as well as extensive trauma that they experienced while living on the street. So as a consequence, many of these youth have difficulty with emotion regulation, and they may engage in risk-taking behaviors such as substance use as coping mechanisms to escape the psychological distress that they experience due to this trauma. And in addition, it's also a common age during adolescence and young adulthood that severe psychopathology starts to manifest. And some of this may be attributed as well to their lifetime of trauma. So it's really important to be aware of this history when you're conducting research with this vulnerable population of youth, and to build a relationship with them when you're doing your research to focus on their strengths, to be non-judgmental and aware of their history of the trauma, and also to follow through with what you say you're going to do, as mistrust of adults in institutions is common for these youth. The second more related kind of methods related point is the importance of collecting extensive data on how to find youth if you're conducting longitudinal research with them, specifically things like phone numbers, social media names and apps that they may frequently use, hangout locations of where the youth go, as well as contact information of their friends and family who might know where they will be really helpful in retaining your youth in this study. I work alongside with Natasha Slesnik and Kelly Kelleher in some research right now evaluating a housing intervention for homeless youth. And Natasha has extensive experience in collecting data with these youth, and the collection of the location data is really important, has been crucial. She's had really great retention rates up to 80% of youth in her study for a year and following them longitudinally. So that's, I think, a real key take home if you want to do research in this area. So I'll stop there. I kind of kept it brief when I was thinking about this, as I recognized our time was moving along, and I'm certainly happy to take any questions people might have.
Susie, how about we go ahead and continue through the panel discussion. I need to learn my alphabet. Susie probably should have gone first. I was looking at first names. So Susie, can you introduce yourself, and we'll save questions for the end?
Sure. My name is Susie Curry. I'm a pediatric hematologist at Nationwide Children's Hospital, and my primary clinical and research focus is in children, adolescents, and young adults with sickle cell disease. I have a K23 that primarily is focused on medication adherence in children and adolescents. I have a particular interest in adolescents, I guess across chronic diseases, but specifically with my patient population, because I know that the disease effects itself tend to worsen as patients go through adolescence, and those adolescents are also at higher risk for non-adherence to their therapies and to transitioning and poor transition. So I have a strong interest in including that population into my research. And I also know that the disease interventions, because the outcomes in these populations are generally worse, you have a higher potential in testing interventions to actually see a difference if you find an effect that those patients are having for improvement if the intervention. A few challenges in implementing in my patient population and multiple studies that I've done. I think most of those things, when I reflected back about what the challenges were that I faced, were really based on my recruitment and my expectations of what these adolescents were able and willing to do, which I think is echoed by the previous speakers about their health literacy and about access to care and the measures that we use. So I think if I could echo strongly that we need to explain research to this patient population, to any patient population that you are interested in studying, and being careful in using the words that you use, and potentially even consider using them in teenage language, which can be very different than what we use with parents or adult patients, for instance. When I first started working here, there were very few patients who had been offered research studies. So there were some myths that I needed to dispel. The classic guinea pig myth was so common that, and many of the patients actually as a clinician did not warm to me because they thought that I was just the person there to push research studies on them. But I found that having that experience and doing this now for multiple years, that I've had the opportunity now that I don't have to, each time I introduce a new study, have to dispel those myths, and they're used to that population. So if you are working with your own populations or have someone who you're partnering with in a specific chronic disease population, I think the first steps and interest in getting that patient population interested in doing research and what it actually means to do research and explaining it can be challenging. But then as you potentially future studies, when you may be reapproaching some of the same patients, it can actually be much easier because they have just a general understanding and they stop seeing themselves as guinea pigs, I guess. I think the other things that I learned was that I needed to be very careful and make it easy for patients to want to do the study and not coercive. So making it easy, meaning I needed to meet the patients where they were at, whether that be in the clinic, whether that be in the hospital, whether that be at some other place, because My interest, like I mentioned, is in adherence, and sometimes patients who are not adherent to medications or to appointments, you have to find them, and whenever you find them, you have to take that advantage as an opportunity to approach them for participation in the study. So I think that is also very key. I think you also need to be careful when Dr. Jackson was talking about the study measures that we're using, making sure, be careful about how those are validated not only across the age group, but also in the method that you're going to have patients and participants complete those studies. So while they may be validated for an in-person completion, sometimes the practicality of doing that in patient populations may be challenging if, for instance, some of the assessments are rather long. So can you be thoughtful on how you administer those interventions so that patients and teens are more likely to want to participate because they can do it electronically or at their own time, or they're not stuck sitting waiting with you for a study that seems quite cumbersome to them. And then I think one of the other big tips that I've had over time in working with my patient population is having them pilot the study, or someone, if you have a patient population you work with or someone within that population, pilot it and see if it would be something that would actually work with your patient flow and your patient and with teens. And seem like interested in before you actually launch it can save you a ton of time and might make the study on the back end because what you were anticipating was going to for them to complete, or that would take a short or something they'd even be willing if you are pilot it with someone that you trust within your patient population, and that can provide a lot of informative feedback you can implement into the future. So I'd be happy to take any questions going forward after the discussion.
Thanks, Susie. Lena, do you want to share some pearls with us as well? And maybe we can summarize a little bit and then shift to some Q&A.
Sure. And I think a lot of what the previous speakers said resonates with me in my work too. So I will try to be brief in adding in some of my input. So I am a pediatric endocrinologist by training at Nationwide, and I do mostly research on fertility and reproductive health. So as you can imagine, that is a fairly sensitive topic. So I can talk a little bit about some of the practical barriers and strategies that we've used. I have a K award funded by the National Cancer Institute to design a family-centered intervention for adolescent boys with cancer who are newly diagnosed with cancer who are considering fertility preservation decisions. So for instance, for that particular project, it is a very sensitive and challenging time in general because the family has just been faced with a new cancer diagnosis. The adolescents can be as young as 12 or as old as 25. So really that emerging adulthood phase. So it's really important for whoever is recruiting that adolescent to really meet the child or adolescent where they're at. Just psychologically. So if the kid is really ill, then the person recruiting needs to be sensitive to that. If the kid is playing a video game, perhaps engage them based on what they're doing in the room, and then using language that really resonates with that adolescent, whether they're 12 or 25, is really important, particularly when we're talking about embarrassing things like sperm banking. And the research staff really have to be comfortable talking about masturbation and sperm banking because we really have to normalize the language because it's already something that for that adolescent, it's going to be awkward and not something they're used to thinking about and talking about all the time. So as Susie mentioned, when we're thinking about studies like this, pilot data are really important to show feasibility when we're applying for funding. So talking to those clinical collaborators and trying to think about where to work these studies into the clinical workflow is really, really important. The second population that I was going to talk a little bit about is my work in sexual and gender minority youth, so specifically transgender populations. And this group is interesting because they're actually quite motivated to participate in research. I think this population recognizes how little has been done and really feel motivated to add to that small amount of knowledge that's out there. But it's really important, again, to work with those clinical collaborators and be really sensitive to things like preferred names and preferred pronouns. Even when you're just walking into that room and starting to introduce yourself and do the consent process, because The second that you use, you know, what they may call their dead name or the wrong pronouns, you can forget it. They're going to have a really tough time engaging with that staff and feeling interested and feeling like they can build that rapport with the person recruiting for the study. One other challenge that we've really faced with that population specifically is that, you know, those transgender adolescents that present to medical care for transitioning, they're really just one specific subset of the general population that's out there. And in a lot of ways, they're the most supported in terms of the fact that they're at least have one parent that's willing to bring them to the clinic to talk to an endocrinologist about hormonal interventions. And there's so many other youth that are out there in the community that we really do need to engage in research to really understand how to improve outcomes for this really vulnerable population. So this is a situation now where it's not enough to just work with the clinical collaborators or stakeholders, but we really need to go out into the community and work with community stakeholders. So for instance, at support groups or in more of the community health center organizations to really build those relationships and think about those how to recruit those youth at the front end when even planning the study design. So I'll pause there, but happy to take questions and discuss any of these points further too.
That's really helpful. Thanks to all three of you. I'm just going to summarize a few of the pearls that you've shared with us so far. You know, particularly with respect to building rapport and trust with adolescent populations, and especially so if you're working with some that have traditionally been marginalized or not included in research, that there are a lot of sensitive topics that we are often asking of them, and we need to normalize some of the language around that, but also help them feel like they're not guinea pigs, particularly when we're collecting some biological samples, which I know Dr. Ford does a lot of, as well as actually all three of you, I think probably do that as well. And that it's really important to understand their perspective, putting ourselves in their shoes. What is their history? How do they prefer to be addressed? Making it as easy as possible for them to participate and really thinking about how do you overcome some of the barriers to finding these adolescents and engaging them in your work. And it sounds like that the importance of having both clinical and community collaborators has been key in all of the work that you three have done, as well as some lessons learned by piloting first before jumping in with both feet. So other things that you want to share with respect to just some of the lessons you've learned from some of the failures that you've had, or things that have just been especially important or worked well across your studies that you wanted to share before we go to the Q&A?
I'll add a little, just since most of my work has actually been in the community, and in thinking of, I think when you're collecting the data, particularly if you're thinking of collecting in kind of biomarker data, and just kind of the logistics on how you need to, the time frame that you have, if you need to have it sent to a laboratory, and sometimes particularly if you're drawing blood, you only have a certain period of time before it needs to be to the lab and centrifuge down and in a freezer. So logistically thinking through some of that research beforehand. I agree, I think partnering with community members and also the participants, youth themselves, having kind of an advisory board, whether it's also perhaps even clinical or community work, I think in particular, having youth on any kind of board that you might have to have their voice represented will be useful. So those logistics of thinking through beforehand, I think I kind of echo the piloting beforehand will really be helpful to recognize what you might need to work on before you go full force.
So I'm going to ask a question. I'll take ownership of the mic here for a second. So I'd like all three of you to tell us how you have met not just the regulatory requirement of informed consent, but the real ethical question around both what Dina brought up in terms of literacy and the cognitive piece of understanding, because I think those are two of the really big challenges when we have adolescents as research subjects. So I'd like to hear about some challenges and some things that have actually worked well, and maybe something that hasn't, around the informed consent question.
Well, I can just provide a little bit of input. I don't know if it's so much the informed consent, but Susie mentioned something about piloting, and I think that's really important. So going back to adolescent participants at different ages and actually asking them to go through survey materials and ask them questions like, what do you think this means? Or, is this question clear? Or would you reword it in some way? I think is really important, because even like for my survey studies, a 12-year-old may understand something very differently than a 21-year-old, obviously. So in my area, I know Jamie talked a lot about psychometrics, Jamie and Kathy, but in fertility-related research in adolescence, there really isn't much out there. So we've done a lot of, with Cindy's help, a lot of survey development and creation. So really starting from very little. So you can imagine in that context that we've really needed to get feedback from participants to understand, like, do they even, are we asking the question in a way that they even understand what we're saying? And that goes through, for the consent documents, but also the assessment tools themselves.
I would just say that I think that assent part of things and making sure that patients understand what we're saying. I don't know if I have great pearls. I will just say that I've learned a lot of lessons as a clinician. When we found out, when we were, for instance, asking participants to participate in a study, or teens to participate in a study, and they didn't, for instance, understand why they were being asked to be on a study about a medication and didn't understand it. So I think it really echoes the importance of it, because they didn't necessarily understand the underlying premise of their treatment, and then that's why they were being approached. So I think I learned as a clinician how we take a lot of things for granted in terms of understanding. I think that one of the biggest things going forward that we should focus on is not taking anything for granted in terms of patients' understanding of what the study goals are, and also why they're being asked, and what their understanding is of, why they might be being asked to be involved in the study. And so just because you sign assent doesn't necessarily mean that you have a great understanding of those things. So I think that's important as the person approaching it, but also as the PI or the person behind the scenes saying, what are you going to do or build into the study that you make sure that that is clear going forward, what you're doing. And so I think providing that background education, because a consent form is only a form, it's not actually proving that the patient understands that.
And I'll add, I think the consent process is always fraught. I think the youth that I'm working with, many of them, the health literacy reading skills is very low. And we typically read the survey questions to them and read through the consent. And a lot of the language that is in the consent forms can sometimes be very daunting. And, so kind of working with IRB to have the language be, the part of the regulatory words that need to be in there to make it more easily understandable for the kids is very important. And I think even just kind of one of the common things that's used in health literacy is kind of like the teach back. So going through the consent and then having them tell you at the end, what is this kind of in their own words, what the study is about, I think can give you a little bit of an idea that they're understanding perhaps what they're being asked to be participating in. And many, I think, not recognizing, youth can be very savvy regardless of their literacy level about what it means to be involved in research. And I think particularly for youth who've been marginalized, they may be even more concerned about what you're doing with their data. And so I think it's important to make sure that you kind of develop that trust and clear understanding so that they feel comfortable and not anxious afterwards.
Great answers. Stuart, do we have any questions from the group?
We do have a question here in the chat.
Okay.
What is the general consensus about need for parental consent in mid to late adolescence in sexual health studies?
So, I mean, I guess out of the three of us, I can take that because my research is probably closest to that. You know, I don't know that I've ever tried to waive parental consent for any of my studies because they're typically in the like clinical context where people are having to make decisions about fertility preservation, where we need the parents' input, both conceptually and also because fertility preservation is it costs money. It's often not covered by insurance. So I will say though, I think if you were doing a study that was not more than minimal risk, you could make a strong argument to the IRB to say that for confidentiality and for some of the points that Andrea mentioned in her talk, that it would make sense to potentially only get consent from the adolescent. I will say, sort of along these lines, one thing that I have, one barrier that I have faced in some of my research is that occasionally we've encountered families where the parent has not shared with the adolescent that they have a diagnosis that can affect their future fertility. And because of that, we cannot recruit that adolescent for that study because by doing so, we may inadvertently clue them into the fact that they have a diagnosis that can impair future fertility, which would not be the ideal way for them to find out that information. So that's one situation that, one scenario that I've encountered in a few different studies where we've struggled and it doesn't feel very comfortable. I think one thing Andrea mentioned in her talk that I thought was important is really that, we're preventing these adolescents from being able to participate in this research, which is, it's important for their voices to be heard. And obviously I think it's important for them clinically to be aware of, their full diagnosis, but that's not, that's out of the scope for this talk. But so that is something that I have encountered. And I mean, to the point where I had a parent ask if we could do a sperm retrieval study with a patient without telling them their diagnosis or, what the implication, which obviously was more than minimal risk. So that was not going to happen. But so I just, and I think Dina answered the question too.
So can I ask, this is Diane Morrison Beatty calling on the line, on the Zoom. I asked the question because I'm fairly new to Ohio and haven't conducted a trial in Ohio. So my trials have been with adolescents, largely mid to late stage adolescents. And every institution, state looks at sexual risk interventions differently. So I was just wondering what the feel was in Ohio. Some places really think you need parental consent. Oftentimes we couple it with STI testing, which helps to provide just the need for the adolescents to consent. But I guess I just wanted a feel in this region. It doesn't seem like there's a lot of studies I can find in Ohio where there's STI testing or HIV testing or stuff going on. So just wanted from your expertise, what your kind of gut reaction was.
Dina, do you want to say a bit more?
So I was just adding that I have found that it is an IRB to IRB variation. Some IRBs, because I've done some multi-institutional stuff, some are pretty lenient with granting waivers, and some are very unlenient with granting waivers. I think we've been successful with getting waivers, particularly in some of the sexual minority work we've done, where the child was not out to their parents, and consenting them to be in a study that included sexuality-related questions could potentially out them to their parents. And that was accepted as a rationale for waiver after a bit of back and forth. So it really, there's no, I don't think, single answer to that question. Depends on the mood of the IRB or its composition on that given day.
Yeah, that's a challenge. Okay.
So I'm going to pull this to a close, and I want to say thank you for an excellent set of presentations today. Our goal was to try to lay out some of the conceptual issues if you're new to trying to do work with adolescents. And so we, pick the area of sort of regulation and ethics, measurement and health literacy. So you've got a great introduction from our speakers on that. And then we hope that the panel was able to provide you with some sort of hands-on experience about their work with adolescents. I would also like to point out that you have now seen 6 or 7 really expert adolescent researchers on either the NCH or OSU campus. So I would encourage you to reach out to them if you're beginning work in this area. There will, I'm sure, be lots of support and help if you need it. Again, thank you to the panel. I think, Stuart, we have a few comments at the end. We will have an evaluation form that goes out, correct?
That's correct.
You will be seeing, and we will be asking questions about next kinds of groups that you would like to hear about in terms of hidden populations. And so if there are other workshops that we can pull together and pull a group of researchers together that can do the similar sort of thing for a different age group or a specific subpopulation that individuals are interested in, sort of doing research with, but maybe haven't gone there. I think we're all aware that we really need to include more diversity in our own research. And this may be new for some researchers. And so we're really here at the CCTS to try to help support people do more research with diverse populations. And so between Cynthia and I, we really are interested in developing out this hidden population series to be a resource for both children's and OSU. You want to just go through those questions, Stuart, maybe?
Yeah, I have the final poll going now about if you'd like to expand your pool of potential research subjects, who would you like to include? So several of you have responded. Others of you could also respond to that. Looks like low social and economic status is one area that people are interested in. Also racial and ethnic minorities, rural communities, and other isolated communities.
Well, while we're finishing that, I would just point out our first series that we did in April did have a rural component, which was an Appalachian rural component, and it was with individuals who are IV drug users. So again, it's a very specific, difficult population to reach and a very difficult area to reach. And so that is one that's been taped, and it is up on the web. So if you're interested in rural, not to say we won't do other rural, but that one is available. Are we?
Yeah, the results with about 2/3 of people responding.
So is that the end of our questions? I can't remember, Stuart.
I think that has covered the questions that have come in.
Okay. So we're ready. It's noon to sign off here. Again, we thank everybody. I know everybody's getting zoomed out. Thanks for bearing with us and getting this workshop in. So, and then you will see some questions, evaluation questions that'll come from us about the workshop itself. Okay. Thank you, everyone.
Thank you. Special thanks to all of our excellent speakers. And I do encourage everyone to reach out if there are other questions after you get back to your labs and back to work. So take care.
And I want to do a shout out for our help with Stuart. Stuart.
Yes, thank you, Stuart. Great job.
So thank you very much.
Excellent job. Bye-bye.
Bye.